It's a long title, but I thought I have to give a meaning to it. My case is that of a patient who's 75 years old, presented with symptoms of acute cholecystitis to the general surgery department, who immediately asked us, because of some aspects of his history, what's going on? That he did say that he had some sort of ischemic heart disease. He was on some sort of medications. So they asked us, and his ECG was basically abnormal. So his diagnosis was chronic ischemic heart disease, unspecified. The patient was not known to our institution before. Patient in reasonable shape, practically normal physical findings, diabetic, hypertensive, smoker, and came in that manner. ECG showed deep T-wave inversions across the anterior leads, ejection fraction lowish. Thallium, strongly positive for ischemia with ischemic LV dysfunction with gated imaging. His labs were practically normal. These are his findings. I'll actually show you the angiogram. This is the right coronary artery, pretty ugly vessel. You can see the disease in multiple areas. It's a combination of ectasia and lesions. A couple of them are pretty tight, others are moderate, etc. But it's extending from near the ostium all the way to the crux. There's also the PLV branch, which is here. It has a short, tight stenosis. You see it here. And this is just to show you the view in a different manner. So from that point of view, I went to the left system, and you can see the LAD is involved multiple lesions, including one of them quite severe. And this is a diagonal branch that's also diseased. There's a moderately severe distal lesion in the circ area. Distal circ is reasonably good. So what would be my plan? I thought, well, I'll do a PCR to the RCA long disease segment, and the question is number of stents, feasibility, and how can I do it? Don't forget, we're in a private sector where number of stents count, and the insurance would not agree with what I would like to do. Second, to do a PCR to the mid-circ, it works a stent. That question has to be addressed. 3, PCI to the LAD long subtotal segment, and the stented, and how many stents are required. So I start with the PCI to the RCA, access, right radial, right femoral. First hurdle, the radial artery does not allow a 6 French to go in. Spastic, so I went in with AL1 5 French, that I had to switch later, and I'll talk about why I did switch. But this is the first beginning. Now it's a 5 French guider. I also elected to use a pilot wire, but I had to switch to another pilot later. So what's next? I thought I'll predilate. So I started predilating. These are the number of pressures and the balloons used. Started with a 3. And ended up with a 3.5, and then up to 24 ATMs or 26 in the previous one. And look how much it took me to get this sorted out. I kept ballooning. In between, I was trying to put something to I can finish the procedure. I couldn't, and I kept couldn't. And now I cannot. Anyway, it's time to stent. So I elected to use only one stent. Big mistake. But to the insurance benefits, yes. Ultra long tapered stent, 60 millimeter. It wouldn't go. Second rule, do not underestimate not well seen calcium in causing no cross. So what to do? Further predilatation with what? Larger NC or what? A scoring balloon. So I decided to go with a scoring balloon, and it did. And I went on. You can see the impact on the balloon. And again, no cross. And these are really large balloons for the vessel. So what's next? Double wire, body wire. Oh, great idea. My chief technician always talks about it. Forget it. No good. No improvement. Still no cross. However, to make things worse, what do you expect? Proximal edge of the stent got damaged by the guiding catheter. And I couldn't even remove it. I said, okay, let me get the whole thing out, and I did. But I shouldn't run out of options. Improve the backup, support by switching to femoral. Now I know I cannot put a 6 French, and I changed to a more supportive 6 French 05 AL. Especially that is radial is spastic. So I switched. Guess what I did next? I fixed the edge of the stent manually because I cannot afford putting another stent. It has to be affordable. Now it's time to resolve this nonsense. Mother and child technique, agree? Yes, beautifully entered. All the way. Right size? Exactly. Drawn for it. Post-dilate, post-dilate, post-dilate. The issue is post-dilatation in these particular patients. So much calcium, it can easily position your stent. Now I have to do the mid RPLV. It's a large vessel, so I have dilated. But the question is, what should I do with it? Put another stent all the way through? No, I could actually, with a guide liner, I pushed actually a drug-eluting balloon, and these are the sizes, 40 millimeter, and dilated and got a good result. The distal RCA at the crux is mild to moderate. I did not touch it neither in the beginning nor at the end. I decided to leave it alone. And I thought this result was satisfactory without the wire. Then the question is what to do else. I thought, okay, I'll go to the left circumflex and LAD, guiding catheter. Now AL 6 French, pilot, same wire, but a different wire, pre-dilatation to the circ. And I'm not planning to put another stent. I still have the LAD. So I put a drug-eluting balloon, 275 by 30, 60 seconds, satisfactory result. Now the LAD, guide wire, I thought same wire will do it. But guess what? It's not exactly a crossable lesion. I'm not in the right mood to do yet another adventure. Look at that. It's totally occluded with probably some auto refilling, but at least certainly not the straightforward. So this angle actually made it extremely hard to get anything beyond. And then I had to go, what? Wire escalation. I kept escalating until a Conquest Pro managed to get through. Now, am I in line? Am I in lumen? Initially, I wasn't sure. Here, I thought, oh, I am in lumen. Only to go out of the lumen after that. And then I still had to refix it. I went out and then went in. Now I'm practically 95% ready to call it in lumen. I'm gonna finish. And what's next? Escalation. Escalation, this is simple. Escalation. And I didn't learn from my previous experience. I put another 60 millimeter stent. It went through actually, and this is the result. Now this is my last slide. Of course we need the right skills, experience, prepare for what we don't like. Issue is not whether we have a complication, it's how to deal with it. Prepare the bed and lesion optimally, select the right tool, beware of obvious, non-obvious calcifications. Invasive imaging should be used when necessary, and this is my final slide. Be modest, there is no such thing, simple angioplasty.